Hi, everyone. It's Angela with Propeller Cure for Crohn's disease, and we're here today for our continuing series about the latest in IBD research. And we're very excited today to have with us Dr. Joana Torres. She is currently with the Hospital Beatriz Angelo and Hospital de Luz in Lisbon, Portugal, as a consultant in gastroenterology, where she is responsible for the IBD clinic, actively combining clinical practice with research and teaching. Her research focuses on populations at risk for IBD and in newly diagnosed IBD, with the aim of finding predictors of IBD development and of disease course. She's involved in several large projects aiming to find predictors of IBD and potentially to develop preventative interventions, such as the PREDICT study, the Early CD study, the Glycan Trigger Project, and the large European Union Intercept project. And welcome, Dr. Torres. You are such a big name in the research field. We're so excited to have you today.
Oh, thank you so much. Thank you. I'm really happy to be here today as well. Thank you so much for having me.
Now, and a lot of these interviews, we interview researchers. They're involved in research full time. You are actually also, in addition to being a very involved in research, you are a clinician who sees patients as well as professor. Now, do you ever see any transfer of your the skills that you bring as a doctor to research, or how does it influence that research? And conversely, does your research influence your role as a GI clinician?
No, so I think that's a very interesting question. To be quite honest, I started to be more involved in research because of the gaps I identified in the clinic. And so when I was a young physician and starting to see IBD patients, I had so many questions on the best way to treat that patient. You know, it's such a heterogeneous disease. It's so important to make the right decision at the right time for that patient, to involve the whole team, to have this multidisciplinary approach. And so I kind of felt more confident on what I was doing by studying more, by being involved in studies, trying to better, go a little behind and trying to understand better the evidence. So this is why I was also involved in the guideline committee at the European Crohn's and Colitis Organization, trying to understand how can we improve care for that specific clinical scenario, etc. So much of the research I'm currently involved, as you said, and I guess we will be discussing more about that, is really about even going earlier in disease course before symptoms. But many of the activities that we have developed in research were transferred to our IBD clinic without any question. I'll give you an example. Ultrasound. When we started performing ultrasound in IBD many years ago, we were the only center in Portugal. So there was a colleague of mine that went to learn, and she brought, and we implemented through a research project initially, first in Crohn's and then in ulcerative colitis. And after we had implemented it, it was, we could not no longer take it back. And so we actively have now many people doing ultrasound in our clinic. Also the same with therapeutic drug monitoring, but when we started, it was something that it was still not, I think, fully standard of care. And so we are doing today, indeed, with larger projects. It may take a little longer to get into clinical practice, I think, for these projects, but we are indeed trying to understand why some people have such a progressive course, with so many therapeutic failures and surgery, etc., and others have such a mild course. And so we are also working in this newly diagnosed Crohn's cohort, trying to follow people over time, to measure bowel damage and to find the predictors for bowel damage progression. So, of course, it may take some time. It takes a lot of time to complete these studies and to make the analysis, etc. But I think, eventually it will feed back into our clinical practice. And for sure, something that I can tell is that my patients that are participating in these studies, because they have, kind of a tighter follow-up, and we have the research team making sure that they follow the procedures, I think they are under kind of even better supervised care because of the additional research projects they are participating.
That's great. That's what we always hope for and are so encouraged by, to actually see that research come to the clinic. And it's so great you're a big part of that process. Now, focusing on prediction and prevention, I know personally a few years ago, I just weren't seeing that much about it. And it's just in the last few years that we've been reading more studies, more analysis of how we can actually, how you all are actually potentially getting to the point of being able to predict. You're seeing things in that area. So what breakthroughs, what brought you to this point to where we're now even, approaching these projects, hopefully with the potential of predicting Crohn's before disease onset? What brought you to it?
So I actually started to work in this topic of prediction and prevention, I think approximately 10 years ago, when I went to Mount Sinai to work with Jean-Fred Colombel, and who had been working on this topic for many years, actually, because I met Jean-Fred, I think, in 2009, and they were already applying for a project which was called Origin. So trying to find the origins of the disease. And I was really passionate about this concept because, of course, by participating in different studies at the time at Sinai, I went through the literature. I reviewed also what our colleagues in rheumatology and diabetes and other immune-mediated diseases had done, and they are way more advanced than the IBD fields. And I really got truly passionate because I think we can learn so much about disease and also have an impact in those patients that have disease, not just preventing disease from happening in potential individuals, but also learning from the disease and maybe having an impact in those living with disease currently. And so I think the possibilities are many because, of course, you can imagine that once we diagnose disease, either Crohn's or ulcerative colitis, I think our evidence is stronger for Crohn's, at least for now. What we are seeing in my mind is really the tip of the iceberg. So disease has gone to a point that people start to feel symptoms and then they get their diagnosis under the, routine clinical care pathways. But what we have learned is that actually disease processes have started many years before. And this has been seen in many other immune-mediated diseases, in diabetes. So people that go into develop type 1 diabetes, they have positive autoantibodies many years before. People that go into develop multiple sclerosis, they will have asymptomatic white matter lesions in the MRs many years before. And, I could speak about rheumatology, Alzheimer. So all the disease processes probably start many years before symptoms arise. And so our theory is that if you can catch, if you can identify those disease processes, find biomarkers that, will let you know that those disease processes will evolve into disease, you can predict disease onset. And then if you can predict disease onset, the next step, obviously, you can make something to prevent disease. And, I think also we need to be very humble in looking at the other fields as well. It may be difficult to fully interrupt those disease processes. It depends, I guess, when we act. But potentially we can modulate disease risk, modulate disease, presentation. We can make disease, maybe a disease easier to manage, more responsive to, to whatever intervention or to our current therapies. And so I think we can push the needle a little behind in time and potentially, we can improve the overall outcomes for those individuals.
Thank you for bringing up the analogies to other diseases. It sounds like that's been a big part in that effort. Now, you mentioned that sometimes we can see these preclinical changes many years before it happens. What are the outer limits of what we're talking to? I've seen studies, several studies, 5 years, 8 years, 10 years, 10 years. Is there any consensus as to how long before it happens?
No. So I think that's a very fair question. And I think the transparent answer is also that we still don't know. So we have had some studies published from Sweden, showing that they had biomarkers that were detectable 16 years before. But we don't really know, we cannot, it's very important for people to understand that this is biomarkers in the serum. It does not, if we would scope the people at that time in, when the serum is drawn and those biomarkers are analyzed, maybe, we don't know, maybe there would not be any lesions that we would classify as IBD. So it's kind of a completely different concept. And we don't know when these disease processes start. I've also worked when I was at Mount Sinai in a project that it's still ongoing, led by Inga Peter, which is the Meconium study, and where we kind of try to understand microbiome development in the babies from mums with IBD. And indeed, we showed that there were differences in the microbiome from these babies. It does not mean that they are going to develop IBD, but potentially it may imply that some disease processes or some of the risk may be imprinted very early on. And so it's also for us to find which are the environmental triggers that need to act, for then disease eventually to progress, to initiate, and then to progress, and eventually people to develop full-blown disease. So I think it's kind of still a lot of things going on. We don't know the answers to all, and we are actually trying to look from different perspectives. We are trying to explore early life, whether, we can potentially modulate some of the risk in early life through environmental, modulating some environmental exposures. Of course, we're not discussing testing babies or giving any kind of drug. This is not what we are discussing, but overall, we know that this period of early life is very important for disease risk in general, not just for IBD, and because it's when the immune system is educated and when the microbiome develops. And so we have this early CD study that you mentioned where we are using baby teeth and blood spots from people that later developed IBD many years later in life, and trying to see whether we can or not identify potentially links to the environment that may have occurred during that time. And then, of course, we are trying to bring together, and this is an effort through the PROMISE consortium there in North America and the Intercept consortium. We're trying to bring together samples of serum that have been collected many years before diagnosis. And so, of course, our limit to answer your question will be depending on how far back we can go. But essentially, by making all these efforts, and this is, of course, as you can imagine, it has a lot of complexities because of sample issues, making, all the things involved. But potentially, we can start to draw the history of life before IBD, so to say. We can better, by having more samples, more data, even if it's very complex to manage and to analyze, we can understand what's happening first, second, I don't know, whether we can actually see that there are maybe different phenotypes that are, or molecular, types of disease that are already kind of coming many years before. So the possibilities are many. And I think importantly, by better understanding the processes that lead to disease and that make disease essentially, at least for now, irreversible because we don't have a cure, potentially we can also find better therapeutic targets and better treatments for patients living with disease. This is at least my hope and expectation as well.
That's a lot to digest, and it sounds very exciting. And I would guess maybe that, and it may vary from individual to individual when the changes start happening. Some people may have a few more years than the other. I wonder about people who have just, a sudden aggressive onset of disease. Is it possible to have a much shorter time frame of these preclinical changes, do you think?
Yeah, so yes, so this is all open questions that we cannot answer for now. You are absolutely right. Some people may have a shorter preclinical, pre-diagnostic period. Some people may have a longer. And we don't know if this is, is a continuum. If you start and you kind of accumulate changes that lead up to the risk, or if some disruptions to your microbiome or to your immune system need to happen through illnesses or drugs or given environmental exposures that may introduce kind of, further changes into your system and make you go into the next level for disease risk. So we don't know that. And this is actually, by making all these efforts through all these consortiums, even if the overall goal is to predict and prevent, we will for sure understand better disease mechanisms and disease biology. I'm absolutely convinced we'll be able to better map which inflammatory pathways are altered before diagnosis and driving disease in those individuals. And potentially we can start also to differentiate, because we have some preliminary data there, whether, maybe some individuals are more likely to develop complicated Crohn's disease, non-complicated Crohn's disease, maybe locations for disease. So I also think this is possible, that we kind of, to answer your question, that we understand better this variability, this heterogeneity of disease by looking at the preclinical period.
And from the research so far, have you detected perhaps certain windows of susceptibility to developing the disease? Is that more known now than maybe it used to be?
No. Yeah. So I personally think that the window of susceptibility may be early life, but this is based on the research I just told you. I think we need better evidence. And also from the overall field of, early life as a potential important period for risk modulation for diseases. But we don't know that for sure. Yeah, no, we don't know. I think what's the big limitation here, Angela, is that we need to, most of the studies resort to serum repositories, right? That have stored serum samples from people that later developed IBD. And so there's a limit to the information that comes attached to those samples. In some serum repositories, there's maybe a little bit more of information. For others, there is not. So, for example, you may not know whether that person was smoking or not. And we know this is a very important risk factor for Crohn's disease. This is just an example. So what we do need is to have prospective studies, such as the GEM study in Canada, led by Ken Kreuterow, and what we'll launch very soon in Europe, which is the Intercept study, or the Intercept consortium, where we will have an observational study with hopefully 10,000 first-degree relatives, where we will follow those people very frequently, and we will ask about lifestyle factors, diet, smoking, drugs, other diseases. And so potentially we can better understand if some changes take place or occur more frequently in those that eventually develop the disease or not. So because from the retrospective studies, I think the resources are amazing. Now we are able to combine all these samples and run this analysis. But to better understand some of the questions you are asking, I think we need prospective studies, which is, of course, very challenging and requires a lot of resources to conduct. But it's very important to have the patients and their families engaged into this effort for us to succeed, quite honestly.
Okay. So one of the important tools is the use of blood markers. What are you looking at? What specific tissue samples or changes in the blood are you looking at when you analyze the disease, the preclinical stage of disease?
So we have, across many different studies and the different cohorts, it's mostly GEM study and then the PREDICT study in the US. Also some studies in Europe with the Swedish serum repositories. People have mostly looked into proteomics, so proteins in the serum. Also into some antimicrobial markers, such as, I think everyone knows about ASCA, ASCA-AGA, ASCA-AGG, antiflagellants, which are available even, I think, commercially in the United States, but it's not something we do currently in clinical practice, at least in Europe. We have looked also into metabolomics, viral exposures. So we are really kind of trying to leverage all these samples to maximize the finding of new information and novel information that can be used either for prediction and for understanding the mechanisms of disease. We have also looked into glycomics, which is the sugars that coat either the host cells or the microbiomes, the microbiome at our intestine cells. So we are looking into many different platforms, trying to uncover biomarkers for prediction and also disease pathways for mechanism, because we can find significant alterations sometimes that are not necessarily predictive, can be used for prediction of disease, but can help us to learn about disease.
And what other changes in the body during this preclinical phase are you looking at in the microbiome, for instance, in that?
So, I think there's very few studies looking at there's a study, for example, from Denmark, where they looked into the routine labs that are made by people, and they were able to see that indeed there are changes many years preceding diagnosis, but probably these are falling outside the clinical range. People won't identify those as clinically relevant. And so studies have shown that maybe those that develop disease maybe have a slightly lower hemoglobin, maybe slightly lower proteins, but it kind of falls outside the clinical relevance, and so it's not given the enough value. So potentially we can develop better tools. We are aiming in the Intercept study, which I told you that we will start in Europe, hopefully. We are trying to look for funding to implement a study with someone from Mount Sinai, with Rob Hirton, trying to leverage also the wearables, trying to see whether changes in heart rate variability, in sleep, if those may precede disease diagnosis. But this is something that we are trying to implement in the study. Which it's what we call digital biomarkers, essentially. It falls a little outside the usual serum biomarkers, but potentially it can bring relevant information. I think it's important to stress that even if I think we are now, it's exactly like you said, we started to hear a lot about many results coming out from these cohorts, and it's gaining a lot of attention, which is nice. I think this is good. It's gaining a lot of attention. But so far, it really remains under the field of research. It may soon change, but so far, people can get advice, of course, about if you have IBD and you have a child and you are concerned, you want to have specific advice. You can get that general advice, even if we may not have a lot of evidence. But like testing for the risk is still under research, and it's not ready yet for practice. So essentially, you cannot come and I want a serum blood, I want a serum drawn, and I want to know my risk. It's still not available. This is still but this is the work that we are doing and that we will do with the Intercept, is trying to validate this a risk tool, either biomarker or biomarker plus clinical risk factors that can help us to stratify and to identify those that really have a high risk for developing disease. And then we can, we can start to design those interventions that may change that risk and eliminate or reduce that risk.
There's just so much that to uncover. I think that, we've generally heard that, or we hear that disease develops in genetically susceptible individuals who have been exposed to perhaps events, episodes, or a series of events and episodes that then trigger the disease. Do you think we will ever be at the point where we might be able to say what triggered disease in an individual? I know that's probably far out, or what combinations affected.
I think it's possible, because today we have the possibility of conducting what we call So you have mentioned genetics, and I think people may be familiar with the terminology genome-wide studies, GWAS, right? Where the whole genome is scanned. And today we have the technology and the platforms to run exposome-wide studies and metabolome-wide studies. So essentially, in the serum, you can actually, run all these platforms that will screen a large number of samples and identify metabolites or exposures that then can be, and of course, then I think there is a lot of work trying to link those to what may be the sources, right? But this type of work is ongoing as well, trying to leverage the resources I'm speaking. And there is one person, my friend Mansi Agrawal in the United States, that is working very actively in this kind of studies, really trying to measure, not just conducting epidemiological studies where we know that antibiotics but really trying to measure and quantify those exposures and developing environmental risk scores that can be used also and applied to individuals to risk their environmental score. So I think it's possible that we come a little closer to better identify negative environmental exposures that may trigger disease or may contribute to disease risk in individuals. Yes.
That's very good to know. And you mentioned this earlier. If you could touch on it a little more, if you identify an individual at risk from looking at them in the preclinical stage, what interventions might be viable? If you could go into more detail about what you're looking at in that area.
So there is very little ongoing still, but I think what happened with our our colleagues, other areas, is that they did conduct a lot of disease prevention trials, not trials for treating disease, but for preventing. And so there are some trials ongoing with diet. There is the Tasty and Healthy Diet trial led by Dan Turner in Israel. There are some, it's not exactly the same, but we are also having a small trial with a glycan supplement, which is a sugar, in people that undergo surgery, because we did see a signal for glycosylation to be altered before diagnosis. And so we are kind of using this post-operative model to better understand how glycans can interfere or impact this, from health to disease transition using the post-operative model. And of course, in the Intercept program, we will have a disease prevention trial with a drug that will be offered to those that are considered to be, based on our risk score, very high risk for developing disease. So I think many different alternatives are actually being explored. I should mention as well the MELODY trial that has been recently completed at Mount Sinai, where pregnant women with Crohn's were offered an anti-inflammatory diet to see whether that has an impact in their baby's microbiome. So it's different approaches, I think, applied also at different stages of what you could consider could be this, life before IBD, these different stages before disease develops.
Thank you. And what many patients are hoping, as you alluded to earlier, is that some of these findings can be applied therapeutically to people who already have the full-blown disease. Do you see those as basically the same as what you just talked about, or would they be modified in some way? Are there any additional?
Yeah, potentially. So I think there is the potential for us to have findings that may lead to for example, either repurposing of drugs or better prediction tools also in patients. And I think a very good example is also we have published on the anti-GM-CSF has been predictive of Crohn's disease development. And this is already a biomarker that has been shown to be associated with ileal disease and complicated disease. And there was a trial with GM-CSF many years ago that failed. And so this is just an example on how, just also by looking at this preclinical period and seeing that these markers indeed important for developing disease, you could potentially lead, to the development of new trials for patients, or, better a better drug targeting this pathway as well. So I do think this is a possibility. I'm convinced this is a possibility. Yes.
And you also mentioned a couple of times the Intercept trial, which sounds very exciting. You're a leader in that. You're taking 10,000 first-degree relatives of patients with Crohn's across many countries. How did this come about? Where are we with it? What's
So this was like, so Intercept is a large European consortium. It's not only a European, we have also a US partner and also South Korea as well. And so many partners actually across the world. And so there is an initiative called Innovative Health Initiative from the European Union, which is a funding mechanism. And so essentially last year we came together. The consortium is led by Gert Dans in Amsterdam and Jean-Fred Callenbel in the US. And so essentially we came together trying to leverage all the work ongoing in North America and in Europe and bring that work together, collaborating, trying to develop the best risk score or risk tool or serological tool for predicting IBD and predicting Crohn's. And so we applied last year. It's a kind of public-private partnership. So we also have some industry, some biomarker industry as well involved, and so some other pharma companies involved. And so we started this year in 2025, but it's very short. We have 5 years to conduct this undertake, which is kind of crazy, but it's very ambitious. And so we are working really on the clock. And so our first step is to validate the biomarkers using the available serum samples in Europe, also leveraging the information from the PROMISE consortium in North America, led by Jean-Fred Callenbel, Ken Kreuteru, and Inga Peter and Ahmed Khalili. I should give them the credit for that. And so once we have this, this biomarker tool, we will start to recruit these first-degree relatives and from Provence with Crohn's disease, and we will follow them through the duration of the study. And we will kind of, on a steady pace, conduct the testing to calculate the risk essentially, and eventually those at high risk will be invited to participate in a trial. It's a very small trial. It's but it's really to understand whether, if we identify someone at risk, can we modulate that risk? And so it just started in February. We had our kickoff in February. It will be 5 years. So in 5 years from now, we will have, I think, many, many, many results to share. Of course, as you can imagine, it's a huge project. There are so many challenges to overcome. The logistics, the regulation around everything, but we are working very hard, to start. And so we are very excited as well, because I think it's a unique opportunity. I think we will learn a lot independently on the result of the trial, but I'm absolutely convinced by studying the first-degree relative population that we will learn really a lot about the biomarkers, also the symptoms that these people may have, dietary patterns, stress, fatigue. We'll look into all of that, how it correlates with biomarkers, how it correlates with the microbiome, and how it correlates potentially with the risk of developing disease. Of course, we don't want people to develop Crohn's, right? But we know that, unfortunately, the first-degree relatives are the ones with the highest risk for developing Crohn's. And many do. So, if we could identify those that will go into developing Crohn's and we could make something about it, I think it would already be a huge undertake. And of course, then the next level would be how to kind of address the general population, because we know around 15% of people have a family history only, right? And still many people develop Crohn's or IBD and do not have a relevant family history. But again, by conducting these studies, we can start to understand better, I think, the mechanisms, the triggers, the causes potentially, and then this information can be, leveraged, I think, to potentially even to the general population. We'll see.
Sounds like a huge step forward, a big advance to be able to carry out this kind of study that should tell us even more. That's fantastic. Now, is this with this study and some of the others, is it usually just adults enrolled in this, or are there pediatric?
So it's not necessarily only adults. So the GEM study enrolled also pediatric first-degree relatives. I also did not mention the multiplex family study at Mount Sinai led by Marla Dubinsky and Lizzie Spencer. They also have many pediatric first-degree relatives, and I think also probants. But for Intercept, so we decided to focus on the age of 16, between 16 and 35, because according to, I think, epidemiological studies, for a first-degree relative, this is still the age, I think, where disease is higher. And so we also wanted to maximize, our chances of, finding relevant information. Also, it's much easier to enroll, because of all the legal aspects of enrolling people under 16. People under 16, I mean, people with 16 and 17 are still considered minor. But there's a kind of easier way to consent them to enroll minors, brings an additional layer of complexity. And so we decided between 16 and 35 for now, at least. Yeah, for now. But maybe, it can potentially change in the future for sure.
I wanted to ask you one last question. If you could find the answer to one specific research question you have probably on your long list tomorrow, what's at the very top in terms of a specific question that you're looking? That's probably not fair. We know all the big questions, but just from a researcher's perspective, is there one particular? I'm sure you have quite a few, but just one for an example of.
Yeah, so I mean, it's very biased because it's still what drives my passion, and most of my research time is this question about why do you develop IBD, right? So why do I have this I don't know, kids in my consultation or teenagers, and then suddenly their sibling is also developing IBD? Why is this happening? And why? And so for sure, this is, on the top of my list, because I think it can be the answer to multiple questions. Then, if we know why, I'm sure we'll develop better treatments, prevention strategies, and better prediction models for those who live with IBD, for sure. And then I think, as a clinician, I see a lot of patients, I think my kind of priority research question is, how can I best select the treatment for this patient, which we don't know, right? We don't know whether it's this drug A, B, or C, or surgery. We don't know. And this is a very important question, because what we do know is that once people start to rotate among different treatments, it starts to become increasingly difficult to get these people into remission, being it Crohn's or being it ulcerative colitis. And I think that potentially, it's because we would need to have the best drug selected the best we could. And, in reimbursement policy, and it's not just about efficacy, but also safety, everything else. And what happens in practice is that we are limited by reimbursement policies that we may have at different countries, either by the national healthcare system, either by insurances, right? And what we need to choose may work very nicely for many patients, but sometimes is not the best for that individual patient. And so we would need to really maximize our chances to get remission, early on, because I think this could be a way to improve disease course and the quality of life of those living with IBD, right? Because if you get the diagnosis, you get the treatment, you are well, then it becomes much more manageable and much easier to live with. But what happens today is that people get the diagnosis. Sometimes they take a long time to start the drug or an effective drug, which needs to also be improved. But once they get that drug, sometimes they do not respond, or they relapse or they lose response. And so it kind of gets into this cycle of trying and failing and trying and failing that, of course, it's not in all patients, but I think it's really, really brings a huge impact to everyone, to the patients, to their families, to the physician, to the healthcare team, to the system, and to society. So, to have this possibility of really predicting what's the best therapy for that patient, I think also would be something very relevant.
I agree. We want to thank you so much for being with us, and thank you for doing what you're doing and taking leadership and focusing on these very important areas that hopefully get us to answers. And thanks again.
Thank you so much.
I'm Angela with Cure for Crohn's disease. Thank you to all our viewers for watching.